First presentation, I would like to invite Dr. Nguyễn Le Hoang Minh. Will present the topic endocardial 3D speckle-tracking echocardiography in patients with coronary artery disease. Please.
Hello, I'm Dr. Nguyễn Le Hoang Minh from Huỳnh University of Medicine and Pharmacy Hospital. Today, I'm going to present to you my report on endocardial 2D speckle-tracking echocardiography in patients with coronary artery disease. So let's get started. Coronary artery disease is a common disease in developed countries and tends to increase rapidly in developing countries, causes regional myocardial disorder. There are ways to detect and assess myocardial function and coronary lesions, including heart echocardiography, myocardial perfusion image, or stress test, and coronary angiography. This is the nomenclature of left ventricular myocardial segments with their distribution according to coronary artery territories, including left anterior descending, right coronary arteries, and left circumflex. If there is any lesion and obstruction in each individual main coronary artery will cause ischemia and abnormal motion in corresponding wall, as described in this image. What is speckle-tracking echocardiography, or 2DS-TE? Speckle-tracking echocardiography has recently emerged as a quantitative ultrasound technique for accurately evaluating myocardial function by analyzing the motion of speckles identified on routine 2D sonograms. A speckle is a unique acoustic pattern resulting from the interaction of ultrasound energy with tissue. It provides non-Doppler, angle-independent, and objective quantification of myocardial deformation and left ventricular systolic and diastolic dynamics. By tracking the displacement of the speckles during the cardiac cycle, strain and strain rate can be rapidly measured offline after adequate image acquisition. The term strain can mean stretching or deformation. Velocity and displacement characterize wall motion. Strain and strain rate describe wall deformation. Because different parts of the object move with different velocities, the object will undergo deformation and will change its shape. Thus, wall motion measurement cannot differentiate between active and passive movement of myocardial segment, whereas deformation analysis allows discrimination between active and passive cardiac muscle movement. So how do we do it? 2DS-TE was performed in 2-chamber, 3-chamber, and 4-chamber views by tracking the endocardial border from images with highest available frame rate. 2DS-TE was also performed in the short axis to track the endocardial layer. Speckle motion was carefully inspected, and segments with poor tracking were manually readjusted and excluded if they exhibited persistently inadequate tracking throughout the cardiac cycle. This is the presentation of 2DS-TE on QLab software. The software automatically traced the endocardial border from the entire left ventricle myocardium and measured layer-specific GLS or global longitudinal strain, GCS or global circumferential strain. Simultaneously, coronary angiography was performed and reviewed by 2 experienced interventionists. Both were blinded with the echocardiographic findings. Diagnosis of significant CAD were considered when more than 50% reduction of vessels diameter presents on at least one coronary artery. Here on the picture, you can see the tracing of the endocardial layer on the upper left image. Then the strain rate was calculated by the software and put on a graph. Then on the right-hand side, you can see the nomenclature of the cardiac muscle, and the strain rate were presented on the picture because to help the physician to easily imagine the abnormalities of wall motion. We have two questions. How are the parameters of endocardial strain on 2D STE in patients with ischemic heart disease? And the second is there an agreement between 2D STE and coronary angiography on the coronary lesions? To answer those questions, we have 60 participants in the average age of 60 to 79 years. Hypertension and smoking are risk factor, and also dyslipidemia. We observed the change in left ventricular function by 2D STE. Firstly, we can see 2D STE has a higher sensitivity and the accuracy for the detection of myocardial ischemia in each coronary artery compared to visual assessment of wall motion abnormalities. Here is the result of 2D STE strain by the software. In healthy individuals, average peak systolic LV longitudinal strain assessed by STE is from the range of -18 to -20. In this table, strain parameters decrease in comparing to normal value. The myocardial fibers most susceptible to ischemia are the longitudinally orientated fibers that are located subendocardially. Measurements of longitudinal motion and deformation are therefore the most sensitive markers for coronary artery disease, despite the preserved left ventricle ejection fraction. We also calculate the correlation of the strain and ejection fraction, and there was a good correlation between the systolic strain and ejection fraction with good statistically significant. Then we assess the agreement between 2D STE and DSA or angiography. These tables compare the wall motion abnormalities on 2D STE and the coronary artery lesions. For the significant coronary stenosis, the agreement of diagnosis between 2D STE and DSA with kappa equal to 0.34, 0.53, and 0.24 respectively in septal, lateral, and inferior walls. We found that the agreement between 2D STE and angiography is not good with endocardial setting of QLAB software to identify the segmental motion abnormalities. Clearly viewed in 2D echocardiography may be not recognized on the endocardial 2D STE. The epicardial strain analysis may resolve this problem in these cases if we change the layer setting of the software. Conclusion: the study using endocardial strain on 2D STE shows the reduced left ventricular systolic function in patients with coronary artery disease. There is a various agreement which is not great about the location of coronary lesions between 2D STE method and coronary angiography. This is either because of the physician technique or either the problems from the software itself. Thank you for your attention. If any of our respected guests have any question, I would be glad to try my best to answer. Thank you again.
A question from the teachers, from the chairman, please.
So, thank you for your presentation. And I would like to ask that and use that. There's a lot of advantage from the two-dimension speckle-tracking. And I would like to ask, would you please compare to three-dimension speckle-tracking echocardiography? And as your opinion, so you get to do 3D or 2D speckle-tracking echocardiography.
Thank you for your question. Now I will try my best to answer. Firstly, the 3D assessment echocardiography can be very precise, and it of course will be better than 2D echocardiography, but there isn't the presence of 3D echocardiography in every department, and there is the obstacle of medical insurance and of course the price. And also 2D echocardiography can provide faster imaging, especially in patients with acute coronary syndrome. We do it fast, then we move the patient to the DSA unit. 3D can be useful in case of valvular diseases, and maybe we can try to use MRI for coronary syndrome also.
Thank you. So 3D speckle-tracking echographies need a complicated instrument, and also we have to use the EKG gauge multi-bit 3D strain. So basically we use more common 2D speckle-tracking echocardiography. Thank you.
Okay. Professor Ernesto Talarico, you have some comments?
I have a question.
Well, I think it was a very good presentation. I'm more of an anatomist, so I would be curious as to why the longitudinal fibers are more susceptible. You think they show increased strain?
Okay. During our research, where we see the muscle shorten to much more during in the longitudinal strain. I mean, much of the ventricular contraction consists of longitudinal and circumferential movement. So in patients with coronary syndrome, we observe that the longitudinal strain is more affected. So according to some research, also they stated that there's various statistical significance says that the longitudinal strain is more affected.
Thank you. Professor Giang, I think you have a question now? Professor Giang. So, thank you. So we move to the next presenter.